We're going to dig into one of the most important skills for medical coders, and that is how to dissect an operative report. So, whether you're studying for your CPC exam or you're working towards an advanced credential, or you're just trying to get a little more confidence with some of those real world operative notes, this video is going to walk you through the exact process for pulling out the important details, and we will code to actual examples. So grab your CPT and your ICD-10-CM books, maybe a couple of highlighters, and look in the description for the links to the cases if you want to follow along and not just have to look at them on your screen, as well as the little worksheet that I put together for you guys. And let's get started. Every operative note follows a pretty predictable format. So each section has different components that are going to give you different clues for what you're supposed to code. So first we have usually the pre-op and the post-op diagnoses. This is what the surgeon thought was going to be wrong versus what they confirmed was that definitive final diagnosis after they've evaluated everything. Then we have the procedure performed. This is a very short, abbreviated version of what they did. We always have to verify it in the details. You as a coder are not supposed to code from that short description of what the procedure was performed. It's sometimes a very good jumping off point to kind of give you some information of, this is what I'm going to be looking for in the body of the operative report, but also look for other things or if it changed or what have you. So it's a good jumping off point, but you're not supposed to code directly from just that procedure performed because you could miss things or things could have changed as they went along. Then we have the indications for surgery. That's the why behind the surgery. Why are we doing this surgery? Findings, that is what they discovered during that process. And then, of course, we have the detailed description. That's the body of the operative note. That's the real coding gold, like what all happened, the entire details of start to finish. They started anesthesia, what kind of anesthesia, this is what we did, this is where we moved from to this organ system, that we pushed this aside, and then they got wheeled into recovery usually at the end, unless it's a minor procedure. Other things that they might include: any specimens that were removed, complications and disposition. So that might be something that we need to look at for modifiers. If we maybe had to add in a 22 modifier because it went above and beyond, or a 53 modifier because they had to discontinue the procedure. When you're first learning, it really helps to stop and be like, it is time to think like a coder, and really sometimes even think almost like an auditor. Like, where is the proof for this code that I want to assign? You have to make that mindset shift, and that can make a huge difference. So what I want to do now is break down a really simple kind of introductory level kind of case and go through that. I've developed a worksheet, so you can download the worksheet as well. It's free. I'm not even going to ask you to put in your email address. It's fine. And we'll walk step by step through the op note, and we'll talk about what we're going to be filling in as we're going through. All right, so I've kind of split screened it so you can see the questions that we're going to kind of look for and the operative note itself. Again, everything is downloadable in the description. So let's break down the worksheet. Well, first we're going to do is we're going to look for the primary procedure. So what's the main thing the surgeon here is setting out to do? And it looks like we can get that information usually from that procedure performed, at least our good jumping off point of it, right? So it looks like they are planning to do a laparoscopic cholecystectomy. What was the approach? Well, it was laparoscopic. So we will have to go into the body of this operative report and verify that it was laparoscopic. Sometimes, not too often anymore, but sometimes they do have to convert them to an open procedure. Or there might be some reason that they had to discontinue it. Maybe the patient's blood pressure went through the roof or something happened that they had to stop, or they couldn't advance their instruments. So that's what we're looking for there. And then, laterality, well, you don't have a right and left gallbladder, so we don't have to worry too much about laterality here. We're just worrying about the gallbladder itself. Additional work, were there any add-on or secondary procedures? So if we look through the operative note, and I'm not going to read it to you because you have all the information. You downloaded it because you're a rock star. If we look through the operative note here, we don't have any additional things that happen. There wasn't any real additional, sometimes they'll find a hernia or something and they'll have to repair that. But this was a pretty straightforward lap chole. We did have a specimen that was the gallbladder that they took out and sent to pathology. So normally when you're doing something where there's an excision, you do have to hold that for pathology. And when you get that final pathology report, that will give the definitive final diagnosis, because there might be some kind of diagnosis that wasn't captured within the operative report. Oftentimes they might take out something like a tumor or a lipoma, and we have to wait for that final pathology to find out maybe it was malignant or it was non-malignant, or what that definitive diagnosis was after it's gone through a pathological examination. This one, as far as assistants and co-surgeons, we don't have any of those. We can tell from the operative report that it just says there was one surgeon. There's no listing here of co-surgeons or assistant surgeons. That might mean we will have to look for different modifiers that we might need to use. If it's a co-surgery, that means that two surgeons did the same CPT code, but we'll sometimes see them. Physicians like to list that they have co-surgeons, but from a coding standpoint, might not be a co-surgery, because from a coding standpoint, what we only code as co-surgery with the co-surgery modifiers is when two physicians are performing the same CPT code, but they're performing distinct components of that. I've actually only seen that a handful of times, to be honest with you. Usually when we see co-surgery, it's more in the clinical sense. The doctor is having another doctor there, and they're performing different parts of surgeries. So one might be doing a hernia repair and the other one might be doing something else in the body. I'm bad at thinking of examples off the cuff anymore. Then completion. Was the procedure finished early? Did they abort it? Did it take longer? That was our 22 modifier. If it was over and above and beyond, and they can quantify what was over and above and beyond. And then possibly instruments, tools that you were used, anything that might change the code selection in there. In this case, we don't really have anything like that. So next we're going to start constructing our code. So our CPT code, we can identify the main term. We could just go into our digestive system and find the section for gallbladders and then figure out what's from there. That's what I like to do for surgeries. With CPT, it's different than ICD-10-CM. The instructions in ICD-10-CM are very clear that you have to look in the alphabetic index, find the right code selection, go to that in the tabular list, and verify it and look for notes if you have to code something before that or after that or in addition to or what have you. CPT, we do not have those same regulations. The guidelines in CPT do not state you have to start in the index. It says you have to find the correct code that best represents that service that was documented. So you do not have to start in the index. So what I like to do is just go to that surgical section. So if I'm looking for gallbladder, I'll go to my digestive section, which is listed here in purple. Now, this particular book I'm using, I actually didn't tab. It might be a little bit faster if I have tabs. So depending on your personal preference, you don't have to tab your books, but you can. So now we're going to go to our section for gallbladder. Now, again, I've talked about this with different sections, but CPT tends to be organized from the top of your body to the bottom. So we're starting with something that's more towards the top of your body, your lips, your mouth, your tongue, your uvula, and then it kind of will start going down from there as far as your digestive system into the esophagus. And then we're going down into, after that, let's see what they have listed, stomach, and then your intestines. So we're kind of going top down when they list them in the directory here. So if we're looking for gallbladder, we will find it in, here we go, biliary tract. Now, depending on which version of the book and which edition and which year, you might have different pages. Don't pay as close attention to the pages because those might have changed. They're going to change in 2026 and 2027. But what we're really looking for is paying attention to the directory. So biliary tract, and we're going to go to laparoscopic because that's what we did. We did a laparoscopic procedure of the biliary tract. If we fully excised something in the biliary tract, we'd be going to this section. So we're going to follow over to the page that it tells us to get to this code range. And here we have laparoscopy, surgical cholecystectomy. Now, some of the other options are if we do a cholangiography with it, or if we do with exploration of the common duct. And that's not what we did. We did the pretty straightforward cholecystectomy. That's going to be what the majority of cholecystectomies you'll probably see these days in age are the laparoscopic cholecystectomy. So that code is going to be our 47562. By the way, just kind of an odd thing to bring up as we're looking at our CPT book here. If you've ever wondered what these little yellow circle dots are, they're for copyright protection. So if you were to take your CPT book and put it into an industrial scanner, like an industrial photocopier, and try to make a photocopy of it, these will block it. They kind of use them, I think, sometimes for money, so that you can't make counterfeit money too. So it will jam. And I've tried it once, and it spit out like an entirely black page. I've had some people say that it's not spit out anything, or it's just spit out a blank page. But yeah, that's what those little yellow dots are for. Now, next we need to figure out our diagnosis. Now, for ICD-10-CM, we do have to start in the alphabetic index. And our diagnosis that we have is symptomatic cholelithiasis and chronic cholecystitis. So a lot of these there's combination codes for. So I'm going to start with cholecystitis, I think. All right, so here we have cholecystitis, and then we have with, and then we're going to look for symptomatic cholelithiasis. So cholecystitis. Okay, so it says cholecystitis with calculus in the gallbladder, see calculus gallbladder with cholecystitis. So we're going to go over to calculus. There we are. Calculus gallbladder with cholecystitis, K80.10. Now remember, we have to verify it in the tabular list. And there it is, K8010, calculus of gallbladder with chronic cholecystitis without obstruction, because there was no mention, and we can always double check. You can always go back and double check that there was no mention of any obstruction. So that would be our codes that we're going to use for that one. It's K80.10 for the diagnosis and 47562 for the lap chole procedure. So no modifiers, we don't have to check for bundling. It's a pretty straightforward case, but this is an excellent starter one to start building up some of that confidence in coding operative reports. Now let's take a look at something that's a little bit more complex. So one step up from that, and that's where we're doing multiple excisions in different areas. We have 3 procedures that we can see here. If we look at our procedures performed, again, jumping off point, we have an excision of subcutaneous lipoma, right upper back, 3.2 centimeters. Excision of pigmented lesion, left forearm, 1.1 centimeter. And excision of seborrheic keratosis, right thigh, 0.8 centimeters. Now, you will occasionally see things maybe marked in millimeters. So a millimeter, 10 millimeters is 1 centimeter. So there is a little bit of measurement, things that you have to do. It is not the provider's responsibility to do the math for you or to do conversions for you. That is your responsibility as the coder. The only thing that you would contact the provider for is if they are missing information that you need in order to code accurately. So those were our procedures. What were our techniques? Well, we did excisions, it looked like. I'm guessing with a scalpel, sterile fashion. And they removed it entirely. So it looks like they did a full excision of those lesions. Anatomical site and laterality. Well, we have one on the back, one on the forearm, one on the thigh. That does come into play for some of these. For lesion excisions, they're oftentimes based off of size and location and sometimes even depth. Were there any add-on or secondary procedures? Well, there might be, because sometimes we have to do closures. Now, with things like lipoma, if this is a lipoma that was in deeper tissue, the closure is included. If it was a single one-layer closure, that's included in the excision of those full excisions of lesions. But we have to pay attention if we have a layered closure or a complex closure, or we did an adjacent tissue transfer. That might be some things that we would have to code additionally for that might not be listed here. Now, if we go through the operative report description, though, which again, you're smart, you probably downloaded it, you're following along, you're amazing. We aren't seeing anything separately that we need to code. There's no additional closures that aren't going to be included in the codes themselves. The lipoma removal is great. We're gonna excise that, and that closure is included. And the rest are simple one-layer closures. Usually, if they're small lesions, they don't have to do too much of a layered closure in them. If it's a smaller lesion, like something that's like a centimeter-ish, it's usually when they're larger that we have to do layered closures or more complex closures on them. Specimens, biopsies, anything sent to pathology. Yeah, we're taking lesions out. We send them to pathology. Now, in this case, I don't give like a pathology report, but in most cases, you would hold this. So if you got this case and the surgeon just did this today or yesterday, it's going to take a few days for pathology to get it back. So in those cases, we're going to hold on to that and we're not going to code it out until we get that final pathology, because we might think that we're taking out a pigmented lesion and it could wind up being a melanoma, and that will change our code selections. Was the procedure finished early or aborted? Nope, they did the whole thing. Oh, I skipped co-surgeons. No, they didn't need an assistant or co-surgeon for this. Instruments, tools used. Let's see, probably just scalpels. They sharply dissected that. Yeah, so they did some cautery. They did some suturing. So yeah, that's about the extent of what tools, other than bandages and stuff, were used. Okay, so let's get into this. We have a couple of CPT codes that we're going to need. We're going to first off need that lipoma of the right upper back. Now, when we are doing more of the OMA type of procedures, the tumors and so forth, like the lipomas, we're going to code them not from the integumentary system, but from the musculoskeletal system. It's just when we're doing into the integumentary layers that we code from the integumentary system. When we're getting down into subcutaneous tissue or muscle or fascia, that's when we're going to look into that musculoskeletal section. But we have to be very careful with these in particular, not to get too far of a tangent in the lipoma coding. But with lipomas, there are instructions that state that if a lipoma is considered to be in the skin layers, essentially, so if it's just in the dermal tissue, it gets coded to the integumentary system codes. I've had providers go back and forth with me on that. They can take that up with the AMA because that's what the AMA states. So in order for it to code to, for example, a subcutaneous layer code, it has to state that they excised it from the subcutaneous tissue. In any case, you guys should know by now that I like to start in my directory. So we're looking for the lipoma first because that's the bigger, badder one. You can go in order if you want, and then just code them in order as you're kind of looking through them in the operative report, and then reorder them later on. That's what I usually do. I'll show you one of the tools that I use to figure out which procedures go first, second, third, etc. So we're looking for the back here, back and flank. Yep. So lipoma right upper back. We don't have a lot of areas right here, do we? We just have these excisions. So we're going to that page, and I'll flip right over here. So this one was one that was right upper back, 3.2 centimeters. So we're going to be looking for, with the 3.2 centimeters on the back. So we have 21931, which is excision, tumor, soft tissue of back or flank. Subcutaneous, 3 centimeters or greater, because this one was 3.2. So we want to use the 3 centimeters or greater. And then we have 2 skin lesions. Now, those are on, it looks like one is on the forearm and one is on the thigh. So we have those kind of bundled by group for a lot of these skin codes. So this group here is the trunk, arms, and legs. So they're both going to be covered from this section here because one is the arm and one is the leg. So one of them, it looks like if I scroll back here, pigmented lesion left forearm, 1.1, and then the other one is 0.8. So we have 1.1 would fall in here, 11402, and then the one that's 0.8 would fall in the 11401. So we would have one code from here and one code for here. We don't combine lesion sizes. We can for closures if they're the same grouping, but not for lesions. Now, as far as checking for conflicts, NCCI edits, etc., um, I know a lot of you like to use Codify, especially if you are in a program with the AAPC. They often include that. So we're going to go to our Codify. We're going to go to our coding tools. Now, this is a paid application, so you might not have access to this if you haven't paid for a subscription. So we have the MCR is Medicare, MCD is Medicaid. I like to use the Medicare ones unless I know it's a Medicaid patient. So edits checker, that will open this up. And this is national. We can set it to our locality if we want. And we can also change from non-facility to facility. I'm just going to type in my codes here. So I have 21931, 11401, and 11402. And we're going to hit the NCCI check. And surprisingly, there's no NCCI edits for these. I thought there would be because sometimes if you do multiple lesions or you do lesions, I guess this one won't bundle because this one was the back or flank. Well, actually, that was included. So I'm kind of surprised that they didn't bundle, but it's saying that they didn't. Now, when we look at what order we're putting them in, they go in RVU order. So what is the most complex, most reimbursed to the lowest? So you can see here the RVU is 14.37 for this one, and then these are lower. So they go in RVU order. And that's because a lot of insurances will reimburse, for example, 100% of the first listed procedure, and then maybe they'll only do half of the following procedures. So that's why we want to make sure that we get reimbursed the most for the highest, most expensive procedure by ordering it first. Now, these technically will need 51 modifiers. Yeah, I could go on a whole tangent about 51 modifiers, but for AAPC purposes, you need them. I've been told by Medicare contractors, please stop putting them on. That's a back end one that the insurances use and not one that you as a coder should be putting on and submitting to Medicare. So 21931 would be our first listed CPT code on our claim form, followed by 11402 and then 11401. And we have to make sure that we attach the appropriate diagnoses for those. So let's get into our diagnoses. So now for this example, I did not put together a pathology report to accompany it. We're just going to assume that the ones that are listed here for the post-operative diagnosis, which it says is the same as the preoperative, were the same that pathology stated. So we're going to assume for these it's a lipoma of the right back, suspicious pigmented lesion left forearm, and inflamed seborrheic keratoses right thigh. So for that, let's start with lipoma. Lipoma is not something that we're going to look for in the table of neoplasms. We are going to check just under the word lipoma. So if we look here, lipoma, we can actually find it under lipoma of the trunk. So the trunk is kind of like your torso. Lipoma of trunk goes to D17.1. Let's check that in our tabular list. So D17.1, benign lipomatous neoplasm of skin and subcutaneous tissue of the trunk. Next, we have a pigmented lesion of the left forearm. Now, as far as suspicious pigmented lesion of the left forearm, that doesn't really state that they have a pigmentation disorder. It really is a lesion that has a little bit of color change to it. Without further specification, I would more so want to go with the unspecified behavior code D49.89. That could be a little debatable. Some people might say that it's just uncertain behavior, but we haven't gotten a final pathology diagnosis. So, it's something that we could maybe query the provider for, wait for pathology report. But I think without having a definitive diagnosis and just saying it's a suspicious lesion of the left forearm, assuming we don't have pathology report or access to it, I would maybe say unspecified behavior would be a safe choice for that one. So D4989, a neoplasm of unspecified behavior of other unspecified sites. You could maybe consider it other specified behavior because it's pigmented. But yeah, I'm open to debate about that one. Lastly, we have a seborrheic keratosis. So we go under keratosis seborrheic. This doesn't say it's inflamed, so it would be the L82.1. So L8 2.1 other support keratoses not otherwise specified. And that's it. So that's how you dissect an operative report. You take it kind of one section at a time. Always ask yourself, like, what is the provider really documenting here? Is there things that they should have documented that they missed out? I can't really code it because they didn't put it in there. For example, I once was working with a coder on a case where the patient had a hysterectomy. In the documentation, the provider said that they went in and they separated the uterus, but they never documented that they actually removed it. So technically the documentation read like the uterus was still inside there, that they didn't actually pull it out. So there was an addenda that was required because we needed to know what method did they use to actually get the uterus out. If you want me to go over more cases like this, definitely let me know in the comments below. And let me know as well if you want me to do more simple, intermediate, or complex cases so that you can sharpen your skills and your analysis as a medical coder. Don't forget to like, share, and subscribe. And feel free to use this in your classes, share with a friend, anything that links directly back to me so I still get the download credit for it. And also, if you have coders that are struggling a little bit, you're teaching them, feel free to send them this video as well so they can get a little bit more confident in their operative reports. As always, I will see you in the next video. And until then, just keep on coding on.